It's live, sir. You can start.
Shall we start or shall we start at exactly 8:15?
You can start, Puneet.
Good morning, sir. Uh, Thank you, sir, for giving me this opportunity to talk on ECMO and its physiology. Today, I'll be discussing about the introduction, basics of ECMO, different types of ECMO, and how the physiology of ECMO is how our body adapts to the ECMO and the physiology of ECMO, the gas exchange, and the interaction of the circuit, the gas surface, and the other organs which interact when the patient is starting on ECMO. So, when do we initially initiate an ECMO? When there is an organ support where our body is not able to meet the oxygen demand and supply, where DO2 and VO2 mismatch is there, and our body needs an organ support in terms of increasing the oxygenation or in terms of providing the cardiac support. Then we go for extracorporeal life support, which is in term, extracorporeal membrane oxygenation. It provides oxygenation to the body. It removes the carbon dioxide, and it helps in maintaining patients who are having cardiac dysfunction. It also helps in maintaining the cardiac support in patients having cardiac shock and all. So the history of the ECMO started way back in 1970s when Mr. Dr. Bartlett, who is known as father of ECMO, started a ECMO for baby newborn for meconium aspiration syndrome known as Esperanza. Since way back in 1970s, initially in 1950s, people used to use a heart lung bypass machine for starting giving an organ support. Later on, as advances in the science and technology, newer membrane oxygenators and all, and compact circuits and all were used. And we started using in the recent times in 2009 H1N1 pandemic, and later on in 2020 COVID when it started. The rampant use of ECMO has given a lot of new era of organ support and extracorporeal life support. So mainly the ECMO is used in various medical conditions like mm, uh, acute respiratory distress syndrome, where our conventional ventilation strategies may not be able to help, and once again, post-cardiotomy, like in patients post-cardiopulmonary bypass and cardiac shock, where they are not able to come off the bypass machine, we can change to ECMO, that is VA ECMO. Acute myocarditis, it can be a viral myocarditis or peripartum cardiomyopathy and all. And cardiac arrest, like in ECPR situations where we see that there is potential neurological recovery is there in those patients, we can start a ECMO. And post heart and lung transplantation, there has been a major role in providing organ support for the next 24, 48 hours till they come off till they are able to maintain their oxygenation by conventional strategies. Types of ECMO, as we all know, there are two, depending on the organ support we need. We can classify the ECMOs mainly into venous ECMO and veno-arterial ECMO. And there are more other different types of hybrid ECMOs, wherein based on the primary pathology, we initiate a one type of ECMO and then may need to change into a hybrid mode, wherein if a patient is started initially on VV ECMO and providing only an respiratory organ support, and then later on, if the patient goes into sepsis or the patient develops a shock and he needs a cardiac support, then we can move into a hybrid mode where it can be a VV or VVA ECMO. And the same thing like we know arterial ECMO, wherein we start ECMO with support to the mainly cardiac function by improving the by providing improvement to the cardiac function. And at the same time, the blood is oxygenated, the circuit goes through, the blood goes through the pump and then oxygenated. Some amount of oxygenation is also done by that circuit, and even the native lungs will also take part in circulation. So veno-arterial ECMO, I discussed in detail how the physiology of the veno-arterial ECMO is different. The word exactly is like physiology we're talking about, but it is usually far different from our normal physiology of the body. So ECMO is almost like the normal physiology will not be the same as the ECMO physiology. And this is almost, I've already told the indications, respiratory failure, cardiogenic shock, and it can also be used as a bridge therapy. As we all know, there are contraindications. The absolute contraindication is the futility of the treatment, wherein you feel the patient is into a multi-organ and stage and irreversible multi-organ damage, and patients who are having terminal malignancies. Those patients, and where you know that the post CPR, the patient's neurological recovery is not acceptable in those cases. That is an absolute contraindication. There are many relative contraindications. Even patients with intracerebral bleed and all, they can use different modified circuits, not heparin, not using heparin. And all. In those situations, also we can use ECMO. So how cannulation is important? Why we need to understand the cannulation of ECMO in the physiology is, as we all know, at the length based on the Poiseuille's equation, the length of the circuit, as you increase the length, the resistance increases. The same goes how we use for a central line. If you need to go give a large bolus of fluids, we prefer a large bore cannula with a shorter length. So length and radius. So the cannula size at the length and the radius of the cannula is also very important. If you choose a smaller size cannulas, then definitely the drainage, the venous return or the drainage which we need to give will be little less. And there are different types of cannulas like a single stage cannula and a multi-stage cannula and different site of cannulation. All these things helps us in making how much adequate flows you want to maintain. If the cannula is of larger bore or larger caliber size, then you may get a good flows. If the cannula is smaller size, then the length is more, the resistance will be more, and the flows will be less. So in VV cannulation, we take a draw blood from our femoral vein, and then put the return back the blood again into the IJV or into any other it can be a um, internal jugular or it can be just femoral. We usually prefer, because it cannot be femoral because it has to be internal jugular. The systemic circulation, it goes into the RA, then again goes back into RV and then into the circulation. So VV ECMO is initiated for patients whose cardiac function is good, or even if the cardiac function is mildly impaired because of the acidosis or because of any other conditions when we initiate because of the hypoxia. So when we initiate an ECMO, VV ECMO, when the hypoxia is corrected, maybe the cardiac function will also improve. So the drainage will be through the femoral and the return will be through the internal jugular. We also have a newer cannulas like Avalon cannula, which are dual lumen cannula, where a single double lumen cannula will be placed in the IJV, where you have a drainage limb and the return limb in the same cannula. The ECMO cannulation is again two types, like a central cannulation where directly into the major vessels we cannulate, and the other is through a peripheral VA ECMO cannulation, a femoral vein to femoral artery or femoral vein to some axillary artery, or directly into right femoral vein directly into right atrium to the ascending aorta. That is central VA ECMO. The key components, as I told, we need to understand is it's first is the cannulas, then it's a pump blood pump, and from there it goes into a membrane lung or oxygenator. And if you want, heat exchanger will be there, cannulas and tubings, all these return cannulas will be there. So these are the major components of the ECMO circuit. The major basic principle of ECMO, why we need to initiate is we need to maintain circulation, we need to maintain oxygenation, and we need to maintain perfusion to different organs to prevent organ dysfunction. So how the oxygenation is maintained is through a pressure, oxygenation is through a membrane gradient. We provide a high oxygen to the membrane, and that is nothing but the membrane is functioning as an artificial lung, and the pump is functioning as a heart. So the major blood flow which goes through this pump and then the oxygenation and the oxygen gradient, it helps in exchange of gases across the membrane. All the flows, blood flow to the ECMO circuit is maintained mainly by the pressure gradient created by the centrifugal pump. The resistance of the circuit component, as I told, if the length is more and the tubing size, usually we use 3 by 8 of the tube size tubings. If it is smaller size tubings, may increase the resistance. Typical adult flow rate, what we need is 3 to 7 liters per minute with a body surface area of 50 to 80 ml per kg per minute. The centrifugal pumps creates a pressure by spinning the impeller blades inside it. It avoids high negative pressures when compared to the roller pumps, which creates a high negative pressures. And the next thing what we need to know is the centrifugal pumps are preload and afterload dependent. So if your preload and afterload is changed, then again the flows may increase or decrease. In contrast to the roller pumps previously which were used, it is not a preload and afterload dependent. It is a membrane, the oxygenator which we use is made. Initially we use silicon membranes and all, which had various drawbacks. So now the recent advances have been changed to polymethyl TMT membranes, that is hollow fiber membrane. It is a vast surface area. It allows exchange of gases between it with a lesser plasma leak compared to the other old silicon membranes. Blood flows outside the hollow fibers while sweet gas flows inside it. So when you take a oxygenator, blood will be flowing outside the hollow fibers and gas will be flowing inside it. But the maximum, this way helps in maintaining the concentration gradient for a gases exchange. As I told, the oxidation in the ECMO is mainly like oxygen moves from a high concentration to a lower concentration, from a sweet gas to a low concentration. Diffusion rate is determined by thickness of the membrane, the surface area, and the oxygen partial pressure gradient. And as we all know that PO2s and PO2 and oxygen dissociation curve, as a steeper part of curve, even in a small change in the PO2s can increase the hemoglobin saturation. But as we go into the flatter part, there will be a no much change even after increasing the O2. So the factors which affect the oxygen dissociation curve, the same applies here also. If we have acidosis and all, there will be decrease in the oxygen delivery to the tissues. Unlike the native lungs, what we say it is 70 meters square surface area, the membrane lung must compensate with a higher oxygen concentration. That's why we need a larger, more blood flows to improve the oxygen content. As I told, the oxygen extraction, in the membrane, like oxygen delivery, the extracorporeal membrane lung is mainly by the gas diffusion gradient and blood flow rate. How much the increase in the blood flow is there, then the more amount of blood flows to the oxygen and more is getting oxygenated, the membrane surface area and the membrane characteristics. So we all know that membrane, different types of membranes are there, polymethylene membrane and all, polymethyl pentene membrane, which is a recent one, which has better performance than compared to the previous one. we we can understand that even this artificial membrane also acts the same like lung. There will be a condensation of gases and all, and that can cause pulmonary edema and swelling of the membrane, then a plasma leak and all. So all these things are slightly reduced in the newer membranes. And the other thing is the sweet gas which flows helps to some extent in preventing this condensation of gases and all. And what we need to understand one more is a rated flow. Each oxygenator has its rated flow, wherein that much amount of blood flow, even blood flow, it oxygenates. Like a few oxygenators have a rated flow of approximately 7 liters, few have 5 liters, few have 8 liters. So beyond that, even if you increase the blood flow or even if you increase the oxygen, there will be no improvement in the PO2s of the patient. The role of the sweet gas, as we all know, the sweet gas is a fresh gas mixture flowing through a blender and it goes to the membrane. It contains, as we tell in the ventilators, a fraction inspired oxygen. In this one, we call it as FdO2, it is a fraction of delivered oxygen at 100%. It creates a concentration gradient for a gases exchange, and a higher flow rate may help in removal of the CO2. We should know, we should understand that CO2 is a very highly diffusible gas, and patients who are having respiratory failure, who initially who are on higher, who are having high CO2s and all, drastic bringing down of CO2 may decrease and have a devastating biological outcomes. So the sweet gas should be adjusted in such a way that the blood flow and sweet gas is maintained in 1:1, and the rate of carbon dioxide to be reduced should be at least 15 mmHg, 15 mmHg per hour. So if the patient is having CO2 more than 120 in a ABG not recordable or a high CO2, you cannot bring back the as the CO2 is highly diffusible. Once you initiate the ECMO, the CO2 may come down very fast. So you need to control coming down on a sweet gas where you slowly start at 0.8 or lower ratios, not 1:1, and make sure that the CO2 comes down at 15 mm Hg per hour. So as I told, the differences between a native lung and ECMO membrane, the surface area is smaller, membrane thickness is little higher. So it requires a higher pressure gradients for maintaining oxidation in our artificial artificial membrane. Native lung is extremely efficient in maintaining both oxidation and carbon dioxide. In this one, the oxidation depends on mainly based on the blood flows and the sweet gas, and it is more easily, as CO2 is more easily washable and diffusible. So CO2 washout is more faster than improving the oxygen. And we all know that we don't target higher oxygenations in VV ECMOs also PO2s or 80, 85 is good enough because as we increase the flows and all, there will be again problem with your membrane rupture, any further other complication of the membrane will happen. So we have to be careful by just targeting higher blood flows or higher PO2s may not be that good, and also the deleterious effects of what hyperoxia may have that has to be prevented. As I told, there is a different areas. First, is the extracorporeal circuits, which acts as a physiological changes in the blood parameters, in like the interaction with the blood surface, interaction with the cannulas, and all that can create a and all the word which was used. Now it is like inflammatory syndrome because of the extracorporeal blood flowing through the circuit that can initiate a inflammatory response. And again, blood surface interaction may has an inflammatory response that may initiate a coagulation response because of the foreign material. And the gas exchange, as I told, the gas exchange happens because of the concentration gradient and all. These all things which we are discussing in the next few slides. The principle of oxygen transfer is mainly based on this mathematical model. The oxygen transfer rate is equal to the diffusion constant into the membrane surface area and the difference of the partial pressure. As we told, the difference in the partial pressure or oxygen transfer is directly related to the blood flow, hemoglobin concentration. We all know the formula of hemoglobin concentration, the oxygen delivery, and membrane properties and the surface area of the membrane. These are all things helps in transfer of how the oxygen is transferred from uh, blood flow through a membrane. When oxygen is flowing through the membrane, how the gas exchange or how the gas transfer occurs based on mainly the pressure, partial pressure gradient and the surface area of the membrane multiplied by diffusion constant. The other factors affecting oxygen delivery, and we all know it's in the native heart, is like cardiac output. In here, it is a blood flow rate and hemoglobin concentration. As the hemoglobin is the primary carrier of oxygen. If your hemoglobin content is low, then the oxygen delivery is low. Oxygen saturation based on oxygen dissociation curve. Initially, when we increase the steep of the curve helps in even a small increase in the PO2 may have an increase in the oxygen content, but when it goes to a flatter part of the oxygen dissociation curve, even a smaller changes may not reflect into your higher concentration of oxygen in the hemoglobin. As I told, the normal delivery oxygen demand and supply is normally between 5:1, wherein oxygen delivery is more than oxygen consumption. But in cases where the patient is hypermetabolic or the patient is in sepsis or the patient is having some thyroid storm and all, when the requirement of oxygen goes, the consumption goes up higher, your body can tolerate up to DO2 VO2 ratio of 2:1. Below that, then your metabolism from aerobic shifted to anaerobic, then the higher level of lactates, anaerobic metabolism, and all goes up. And to match that, we need to maintain the blood flows. And at that point of time where you need to maintain the supply to the patient, then that's when you initiate an ECMO. You maintain a balance between DO2 and VO2. Carbon dioxide removal, as I told, it's mainly based on the diffusion of gases. It is highly diffusible. It is maintained by sweep gas. If you increase the sweep gas flow, there will be a washout of carbon dioxide. We should be very mindful about how much carbon dioxide is being washed out. It should not be more than 15 mmHg per hour. And this is a basis wherein if the patient's cardiac function is good, newer concept of extracorporeal carbon dioxide remover only is being practiced now. So wherein we don't use an oxygenator, we use a pediatric oxygenator and a sweet gas wherein, or we can use an oxygenator with a dialysis machine wherein the patient carbon dioxide can be washed out in patients who are having. And we have done a few cases here wherein we have used Indian method of ECOR just by using a dialysis machine and connecting it to a pediatric oxygenator, and the blood flows through it, and through dialysis machine, the pump acts as a dialysis machine, and the blood flows through it, and it helps in removal of carbon dioxide. It has been tried and mainly by Dr. Arpan sir. So, and we are also following in our unit wherein patients who comes with a COPD with high carbon dioxide and all, we have tried in patients, so the conventional ventilation strategies did not help in the carbon dioxide removal of the gases. The Haldane effect, we all know as the oxygen hemoglobin, like the concentration of PO2 has increased, there will be reduced affinity for CO2. So the CO2 detaches from the hemoglobin, and this can be like CO2 removal happens based on this phenomenon, wherein when the oxygen improves, the CO2 gets diffuses out, and the CO2 is washed away by the sweep gas. So, ECMO versus mechanical ventilation, when your normal ECMO, mechanical ventilation strategies did not help in improving, that's when where we put the patient on ECMO. And the main concept of putting a patient on ECMO is to provide lung rest and recovery. And the same thing happens in VECMO, wherein you do not increase the afterload by just maintaining a blood flow. You have to provide a cardiac rest also. If your cardiac is poor and the patient initially may require a full ECMO flows, but later on the complication of the ECMO, again the patient goes into cardiac stemming and all. We need to know the venting strategies to maintain that. How do you promote again the physiological effects of priming of fluid? Also, when we prime the circuit, the priming fluid also have an impact on the physiology, the physiological changes which happens. The crystalloid primings may cause hemodilution if the patient is already anemic or the patient is having low hemoglobin. The hemodilution can have a bad impact, and the oxygen delivery might be affected. So in that patients, we may need to use a blood priming where we need to use the fresh blood, not the stored blood, wherein again the patient may have hyperkalemia, hypocalcemia, and all that acidosis may there that can cause again further lung injury and other organ injury. And the problem with the blood priming is if the large amount of volume goes into the patient, then the problem with the transfusion related acute lung injury can happen. In patients who are having again hypovolemia and like hemodilution by giving lots of fluids, albumin is being tried, but again the problem is the cost and also the problem because of the high oncotic pressures and volume overload, and also the problem with the acute worsening of the acute lung injury. Hemodynamic effects on BV ECMO, as we all know, the circulatory impact with the BV ECMO is minimal, but as the blood is drawn from the venous and returned to venous circulation, it is not a direct support to the heart, but indirectly it helps when the oxygenation is improved and all. So it may reduce the hypoxic pulmonary vasoconstriction, improving the right ventricular function indirectly. Again, the other drawback of VV ECMO is if you increase the flows and all, the pulmonary arterial pressure goes up higher and the patient may goes into RV dysfunction. In that scenarios, we need to have some inotropic support that helps in RV function to get better. So in VV ECMO, the again problem if your flows are higher and your pulmonary artery pressure goes up higher, the patient may have a RV dysfunction. So in those scenarios, we need to improve the RV function by adding some inotropes to the patient. In VECMO, the hemodynamics of the VECMO is a complex. We need to understand that it is a parallel circuit wherein you are taking drawing a blood from the vein and giving the blood into the artery. So it is a parallel circulation to the native cardiac output. It reduces the ventricular preload. When we draw a blood, so RV preload is decreased, but venous blood is diverted directly to the drainage cannula. But at the same time, your left ventricular afterload is increased as you are giving the blood into the femoral artery. So mostly in cases of peripheral VA ECMO, so it may worsen the ventricular distension in patients who are having severe heart failure. So it is a complex flow pattern which is being created. Your afterload, your blood flow which is entered into the femoral artery is again mixing the blood with the native. If your native function of the heart is slightly maintained, there will be a mixing zones and there can be a problem which can arise. I'll discuss in the slide, which is differential hypoxia may happen. Initially, if the patient is in full ECMO flows, the problem of differential hypoxia is not there. But if the patient's heart function is improving, cardiac function is improving, and the native circulation is maintained, that's the point wherein your differential hypoxia occurs if the patient's lung function is bad. If the lung function is good, so at least the problem of differential hypoxia comes down because your native circulation oxygenation is maintained by your native lungs. The initial part of the brachiocephalic and the right brachiocephalic and all is maintained by the native circulation and the coronaries. That is maintained by the native circulation which receives the oxygenated blood from lung. If the native circulation is not getting properly oxygenated by the diseased lung, there's a problem wherein the differential hypoxia arises. The major impacts of preload in VECMO, there is a significant reduction in venous return because the whole blood is taken out from the RA. And in VECMO, there is a minimal net effect is drainage equals the return. Hypovolemia can cause shattering the drainage cannula. As I told you, the hypovolemia is there, then the drainage will not happen properly, and at that point of time, in that situations, like multi-stage cannula may help, but only thing is again, if there is hypovolemia, your drainage may not happen. And preload management is critical for balancing the ECMO and the native heart function. If your flows are not maintained, then again your cardiac function may get affected, your oxygenation may get affected, your blood flow is maintained, and the organ crosstalk which happens with the renal, with the kidney, with the liver, all those things will be affected. Afterload in VV ECMO, nothing, no direct effect on the afterload. But in VA-ECMO, it increases the left ventricular afterload. As I told you, you're giving the blood peripheral into the femoral artery that can worsen your pulmonary like LV function, and it can cause pulmonary edema. And in severe cases, the patient may require your venting strategies. So as I told, when you have a low in the problem here, what it arises when you have a VA ECMO and you're giving blood to the femoral, returning the blood to the patient through a femoral artery, when there is low ECMO flow. So it is relatively when there is low ECMO flow, when the native cardiac output is good. So wide pulse pressure is normal or a wide, and you have pulsatility of the arterial waveform, and as there is a greater contribution to the native cardiac ejection fraction, your blood to the upper part of the body is well maintained, because there is you are giving the oxygenated blood to the femoral artery. It is more oxygenated blood is going to the lower part, and the upper part, if your native function is maintaining good, then the upper part of the body will also receive a good oxygenated blood. And the waveform normal or nearly resembles the normal arterial pressing. But when the patient is on a higher ECMO flows, that's when the problem, like not exactly the problem, that's uh, when you need to be careful about what exactly has to be done, how you have to manage the patient, maintaining the circulation, how to avoid the pulmonary edema, how to maintain, how to unload the LV, because when you are giving a higher load after load from a femoral artery higher up and it goes to that, and LV function IV function is impaired because of the high afterload. How to maintain that? In those cases, the patient may have a narrow pulse pressure. There will be no pulsatility, and there will be a continuous flow pattern. And you have to more rely on the mean arterial pressure rather than systolic and diastolic. And to reduce that, if the patient is getting pulmonary edema and worsening, you may need to plan for a LV venting strategies. Maintaining adequate tissue perfusion, as I told, it all depends on how much blood flow is maintained and the characteristics of your oxygenator or oxygen lung artificial membrane. And also, to some extent, if your native cardiac output is good, the perfusion to the other organs is also maintained. What are the different parameters we need to monitor in the patient? As I told, in BV ECMO, there is no major problem with your cardiac function. So your mean arterial pressure, pulsatility is maintained and all, and mixed oxygen mean saturation more than 65. Lactate levels coming down because of the perfusion is maintained, oxygenation maintained, your aerobic metabolism goes up and your lactate levels comes down, and you need target urine output more than 0.5 ml per kg per hour. The major heart lung interaction which happens on a patient in ECMO is like decreased pulmonary vascular resistance, because when you increase oxygen, the hypoxic pulmonary vasoconstriction drive goes off. So you will have a decreased pulmonary vascular resistance. But this becomes a complex issue when your blood flows are very high. The PAP goes up, that can cause your RV dysfunction, as we discussed earlier. As the oxygen demand, as the oxygenation is more, there will be reduced work of breathing. Right ventricular function improves initially, but if the flows are very high up, and then it can cause your RV dysfunction. In VA ECMO, the problem with the left ventricular function will be like LV distension can happen, and this can be managed by like different troubleshooting when we discuss the class in the next coming Tuesdays, when we discuss about the troubleshooting and complications of the ECMO. In that, we'll be discussing about how we unload the left ventricle. And this was discussed earlier, how the oxygen delivery by the delivery is based on the oxygen content, arterial oxygen content, and the hemoglobin concentration, and native cardiac function, cardiac output, everything. It all depends on these three factors. So if the patient's oxygenation is not maintained, you need to know what other ways you can improve your oxygenation of the blood by giving hemoglobin or by increasing the cardiac output, wherein ECMO we increase the cardiac output by increasing the flows and blood flow. If you increase, then that these are the factors where we can increase the oxygenation delivery to the patient. And where we target usually in a critical care like repeated transfusion strategies, but in ECMO, if we increase the hemoglobin up to 10 or 12, again we need to understand that increasing hemoglobin more concentration can cause increase in the viscosity and then again in the blood clots and all. So that scenarios and all that has to be maintained, wherein your perfusion, your oxidation content is not only by increasing the oxygen, but also by like it increases the viscosity that can be deleterious to your membrane. The other thing what we need to understand in VECMO is like increasing the oxygen when we increase the blood flows, and if the native heart function is good, that's where I told there's a mixing point where you return the blood to the patient through a femoral artery, and the native circulation is also maintained. If your lungs are good enough, then only the upper part of the body will receive oxygenated blood. If your native circulation, your heart function is good and your lung function is good, then this also will receive the oxygenated blood. The problem arises when your heart function is improving and your lung is not improved and your lung is not able to maintain the oxygenation. That's where the problem arises, and your the upper part of the body will receive deoxygenated blood, and the lower part of the body will receive oxygenated blood. This is called as like North-South syndrome, and it creates an area of watershed wherein the upper part and lower part there will be a mixing point. This is called as mixing cloud, wherein this is a point where your oxygenation is not matched. So the term now initially it was Harlequin syndrome and North-South syndrome. Now we call it as differential hypoxia, where the upper part of the body is hypoxic and the lower part of the body is hyperoxic, and the area where the mixing happens is called as mixing cloud. So based on the LV, like LV functioning improving or LV functioning worsening, we need to check the right upper limb saturations to know what exactly how much amount of the oxygenation is maintained, and at what point, as we know that any the upper part of the body is the brain, which is more important. You need to monitor the brain oximetry, or if you have near infrared NIRS, that will be helpful in assessing that. And your mainly your right upper limb, if you don't have these advanced techniques, you can just monitor the oxygen saturation in the right upper limb. That will be helpful in monitoring how much oxygen is going to the brain. As I told, the impact of the extracorporeal circuit on other organs will have a organ crosstalk will be there. Acute kidney injury usually happens pre-ECMO when the patient is hypoxic, and when the patient is like hypoxic and hypovolemic and all, that can cause renal injury initially, and that can initiate inflammatory activation and all. That patient may have initial 2 days acute kidney injury. Liver dysfunction, again because of the decreased flows when the patient is hypertension or all, that can cause hepatic dysfunction initially. And when we maintain the circulation later on by increasing patient putting on a cardiac circulatory support like VECMO and all, there can be improvement in the liver function. Neurological considerations, as I told, coming down on the carbon dioxide in VV-ECMO and in VA-ECMO, the differential hypoxia, these two things majorly impact your neurological outcome. So maintaining and the other thing is the hypoxia, acidosis and all, which were there because of the organ dysfunction before initiation of the ECMO, that can have secondary impacts on the neurological outcome also of the patient. As I told, the cold again, if the patient's blood volume is going to the extracorporeal circuit, there will be a heat loss. So we have a heat exchanger in the ECMO circuit to maintain the temperature the proper way. If the patient is hypothermic, again the lethal threat of hypothermia sets in. Then again the patient may go into a coagulation abnormalities like DIC and all bleeding, as already the patient is on like anticoagulation to maintain the circuit patency and the membrane function. The second effect which can cause impact on the hemoglobin is because of the centrifugal pump and all, there will be sharing stress across the RBCs that can cause hemolysis and all. But the newer membranes and all have a lesser impact. The centrifugal pumps have a lesser impact on this hemolysis. But as the patient goes into extracorporeal circuit, also that can initiate hemolysis. how can you monitor it by different methods where you can measure plasma free hemoglobin, serum LDH, and all. You can follow up and decreasing the flows. If your oxygenation is maintained, your PO2 is maintained as around 80, 85. Saturation is saturation is 85 to 88, and PO2 is around 70 or 60 to 70. Then you can come down on a blood flows. So no need to target a higher blood flows and saturations of 100% or PO2s are more than 100. Inflammatory response, as I told, the ECMO inflammatory syndrome is similar to the SIRS because of the complement activation. When the blood flows to the extracorporeal circuit, it triggers the release of the cytokines, complement activation, monocyte active, pro-inflammatory cytokines like TNF alpha, interleukin 1, interleukin 6 are released, and it can create activation of a coagulation cascade. So more often now, the recent advances have been applied to prevent how we can decrease this inflammatory response, ECMO inflammatory syndrome, by modern biocompatible methods of decreasing the inflammatory response with the extracorporeal flow of blood. The complications, as I told, we'll be having further sessions of the ECMO, wherein the different complications which arises after creating a patient from initiation to like decannulation, or what all things can be happening, troubleshooting, which we'll be discussing in the next coming Tuesday classes. Bleeding is again because of the activation of the one thing is because of the hypothermia that can happen, and one thing is because of the coagulation cascade, because of the inflammatory response of the ECMO. Thrombosis, where we need to maintain a proper anticoagulation to prevent the membrane getting clogged and to have adequate oxygenation. The main idea what we need to start, what we thought of initiating ECMO is to maintain a proper delivery of oxygen. If your delivery of oxygen can be hampered, if your membrane is getting clogged or thrombosed, so we need to, different methods are there when we need to understand the membrane function. We measure the pressure differences, P1, P2 pressure gradient, wherein P1 is a pre-membrane pressure and a post-membrane pressure. Transmembrane pressure, if it is going, different membranes have different transmembrane pressures. If your transmembrane pressure goes higher, more than 70 or 100, then it means your membrane is getting clogged. If your membranes like macula membrane, your transmembrane pressure difference is only 20 to 30. But for like urosets and all, your transmembrane pressure goes can be tolerated up to 70. If more than 70 or 100, then think that the membrane function is gone. As I told, the neurological complications that can arise, which we have to be careful. The physiological cerebral perfusion and the cerebral oxygenation has to be maintained, which has to be monitored. If you have a advanced units like NIRS and a transcranial Doppler, which where you can monitor the cerebral blood flow, that is more important. These are the complications which arise because of the cannulas and the membranes and the different extracorporeal circuit which we use, which we connect us, and all that can cause you the infections and all. The major parameters for gas exchange, as I told, the pre-membrane and post-membrane we measure, and the delivery of oxygen is by the CO2 remover. The delivery of oxygen to the delivery of the fresh gas helps to understand how your CO2 is washed out. And we measure as normal monitoring, we monitor PF ratios, arterial venous oxygen concentration difference, lactate trend. As we improve the blood circulation and oxygenation, perfusion is maintained, the lactate clearance happens. Circuit performance monitoring is also one more important thing which we need to understand. We have got ultrasonic flow sensor which measures the blood flow, and a sudden drop may indicate hypovolemia, tandem malposition, or a circuit obstruction. As I told, pre-membrane and post-membrane pressures are monitored, and regular inspection of the circuit to measure for any air bubbles. We call it a torch test, wherein we use a torchlight and check for the thrombosis or any clot formations in the oxygenator. That is visual inspection of the oxygenator. As I told, as a patient, we need to understand if the normal, it's not just the ECMO physiology. We need to understand that we are connecting the patient to an ECMO. We need to understand, we need to know that the lung pathology or cardiac pathology which was there, we have to address that also. We have to give that rest. That should not be forgotten by considering only the extracorporeal life support, by forgetting the normal physiology of the patient. We need to monitor all those things also simultaneously, same time. When, as I told, the main idea behind is to maintain the delivery of oxygen and the consumption. So the balancing needs between the DO2 and VO2 has to be maintained. If your patient is going into like increasing the oxygen consumption, because it can be because of the fever, it can be because of any other condition, it can be hypermetabolic response, or it can be an hyperthyroid or hyperthermia. All those things that has to be managed by by increasing the sedation, by making neuromuscular by administering neuromuscular blockade, and if the patient is hypovolemic, giving more fluids. All these things has to be maintained. And what we need to understand is extracorporeal circuit. When we connect the patient to extracorporeal circuit, there will be the drug sequestration. So you may need to give a larger amount of like sedations or analgesics to maintain patient decreasing in the oxygen consumption. Uh, on the patient, as I told the patient, if the patient develops a renal dysfunction because of pre-existing pre-initiation of the ECMO, or even after initiation of the ECMO because of the inflammatory mediators, the CRRT, inline CRRT is the best modality to start with, because normal conventional dialysis may have impact. Like as we connect to the circuit, we can connect to the circuit or we can place IPC, but usually when the circuit is there, we usually connect the patient through the circuit only. So if we connect a normal dialysis machine, so that can cause again drawing of blood, the blood flows can be hampered. So preferably we need to think of using a CRT when the patient is on a pulmonary functions already I discussed. Uh, These all things that we have been already discussed. And the other thing is, as I told, the second problem which can arise in VV ECMO is the problem of the recirculation. We need to understand that the drainage cannula, which is draining through the femoral vein, is into the IVC, and the return cannula is into the SVC. If the distance between the SVC cannula and the IVC cannula, if the draining cannula and return cannula is less than 8 centimeters, then you may have recirculation happening. We are draining blood, your ECMO circuit will be draining the oxygenated blood. So usually what we say is the gap between the drainage and the return cannula should be approximately 10 to 12 centimeters. So we may have if the patient is having recirculation and the your oxygenation is not maintained, then we need to calculate a recirculation pattern with this formula. So it is a pre-membrane saturation minus the SVO2 by the post-membrane oxidation and post SVO2. So these have the interface between like cardiac output is not like the blood which is going into the cardiac native circulation is not it's not the oxygenated blood, because the oxygenated blood is getting drained by the return it's getting drained by the drainage cannula. So your native circulation is getting deoxygenated blood. The oxygenated blood which is returning to the heart is again taken by the your drainage cannula. So recent advances in ECMO, we are using biocompatible surfaces like heparin-bound polymers, phosphorylcholine coatings, and which can and albumin mimetic surfaces which can decrease the inflammatory reaction and the thrombogenicity. Advanced oxygenator designs, like as I told, PMP is the recent advance, and fiber optimized gas exchange surface. And while it can also help in like it increases the flows and it helps in minimizing the prime volume and resistance. Anticoagulation, as I told, there are heparin coated circuits now where we can use low dose heparin and all for initial periods, and later on when we like the patient goes for a longer ECMO and all, when we change the circuit or it goes at the end like after a period of 1 week or 10 days, at that point of time the efficacy of these heparin coated circuits may come down. So a longer acting materials where we can use heparin-free circuits are also being tried. And the last, before concluding, I need to just tell that the ECMO survival rate for adult ECMO is 59% for VV, and for V ECMO it is 42%, and ECPR is 29%. The key physiology, what we need to understand is, as I told, in VV ECMO, the main problem will be the recirculation, and the delivery of oxygen is mainly based on your you're mainly based on your blood flow, your oxygenation of the membrane, the rated flow of the membrane, and also with the rated flow and the oxygen delivery capacity and the oxygen gradient, membrane surface area, all those things carry. And the problem with the recirculation we need to correct is, even when maintaining your blood flows, and if your cannulas are too near and it is oxygenated blood is getting again drained back into the ECMO circuit, then there's a problem with your VV ECMO that has to be considered. In V ECMO, the main problem is with the LV distension and also with differential hypoxia that has to be considered when you are managing the blood flows and oxygenation. And meanwhile, you're considering the preload and an afterload. So you need to come down and lower flows, maintain the lower flows so that your LV distension can be prevented. Newer techniques have been developed wherein you have automated control systems using based on the data which you enter into the AI that can be helpful in assessing your blood flow rates and your seed gas flow rates. And you have a mobile ECMOs wherein patient can be ambulated based on if the patient is created on initiated on a VV ECMO, which is a dual like Avalon cannula, wherein the patient can be mobilized. And you need to understand that when we are providing multi-organ support, the best modality of treatment like renal replacement when have to provide you need to provide CRRT which will have a lesser impact and on the blood flows and all and your oxygenation and the main idea for what we have initiated the ECMO will be solved. See, it's an interdisciplinary role between an intensivist, nurse, perfusionist, and a surgeon. And as most of the cases we are doing for percutaneous cannulations, but still cardiovascular team has to be available, and it is mainly a multidisciplinary approach. So in the end, what I need to say is that we need to understand how the gas exchange happens, how the hemodynamics, how the cardiac physiology, the preload and afterload, everything is maintained and the body interactions is being optimized. Different ECMO modes are there. First, basic ECMO modes are veno venous and veno-arterial ECMO. And based on the complexity of the disease and further worsening, you need to modify your ECMO strategies. Like you need to opt for a hybrid modes of ECMO. And the most important we need to understand is anticipating any complications, and proper vigilance is must for any ECMO to run successfully. So the success of ECMO therapy depends on the appropriate patient selection, timely initiation before the irreversible organ damage happens, optimizing the physiology of the patient and also with the circuit, not only forgetting the normal physiology of the patient, and vigilant monitoring of the complications and disciplinary skilled interdisciplinary teamwork is must to have a good successful ECMO run. The references is also guidelines, ECMO physiology handbook, and international ECMO network from the net. Thank you, sir.
Thank you, Kadir, for taking us through the complex physiology of ECMO. I think all of us from intensive care, even if you're not doing ECMO, we should be aware because of the increasing use of ECMO services, and you may never know when you might need to put somebody on ECMO. We need to understand the subtle differences between the VV ECMO and VE ECMO, and until unless we know the physiology, it becomes difficult to understand the changes that happen. We will continue with the series on ECMO over the next few weeks, where we will try to address different aspects of ECMO, including troubleshooting, including the anticoagulation strategies, and including how do we troubleshoot during ECMO. Thank you very much. And if you have any queries, please do get back to us. We will revert back with appropriate responses. Thank you. Thank you, Kadir.
Thank you, sir. Thanks, sir.
Becoming a nuisance, the levels traffic.